Welcome to Real Clear Radio Hour, brought to you by the Competitive Enterprise Institute. I'm your host, Bill Frezza. This week, we tackle the war on cancer with a pair of guests from opposite ends of the battlefield. In the second half of our show, we'll speak with theoretical physicist Paul Davies, whose move into cancer research is shaking up the world of big science. Up first, we're pleased to welcome Steve Bonner, entrepreneur in residence at the Arthur Rock Center at Harvard Business School and former CEO of the Cancer Treatment Centers of America. Steve, welcome to the show.
Thanks, Bill. Great to be with you.
Steve, before spending 15 years running one of the most unusual healthcare providers in the country and being named one of America's 100 most influential healthcare executives along the way, you worked your way up through some pretty interesting businesses. Give us a capsule summary of your background before you got into the cancer treatment business.
Sure. So I'm a Minnesota native and got back from college and wound up going to law school at night and started working in financial services during the day to pay for my law school. And I actually spent the first 25 years of my working life in financial services and migrated out of being a lawyer into general management.
So you made an honest living.
I tried to make an honest living with a real passion for general management, for innovation, and ultimately migrated to a very tight focus on the consumer experience, and building businesses out from the point of view of what would a consumer really value. And so I worked in major insurance companies primarily, but worked with bank product and insurance product, and went from standing starts with a couple of these new products to multi-billion-dollar businesses.
So that must have been quite a training ground, but not one for healthcare. I understand that the Cancer Treatment Center of America was founded by a fellow named Dick Stevenson, who launched the business after a life-changing experience. Share his story with us.
Dick is a entrepreneur, an investment banker. Dick never had any experience in healthcare until, guess what? His mom got very severe cancer. And with Dick's international reach, he said, I got to go find some help for mom. And he went around the world and he came back with some very creative, innovative, and he thought worthy innovations that could be helpful to her. And as he approached her bedside, he was confronted by the FDA, the AMA, the insurance companies, all of whom said, no, these are not approved for therapy here. And so as his mother died, an untimely and a very unhappy death, Dick said, gee, it seems to me that in healthcare, the bureaucrats care a lot more about the bureaucrats and the bureaucracy than they do about the patient.
But that's because that's who the customer is. His mom wasn't the customer.
Right, exactly. And the bureaucracy was the customer. And so Dick said, in my mom's memory, I want to create a place for cancer patients to go where they're the center of the world. And if they come to me, my job is to manage the bureaucrats. And part of the irony is that of the therapies that he brought to his mother's bedside 25 years ago, virtually all of them are now mainstream models of care in oncology in the United States.
But he wasn't allowed to be an early adopter.
He wasn't allowed to be an early adopter.
So did that set him up as an enemy of the FDA and the AMA and the insurance companies? How did he work that out?
Almost a loving critic, but not quite loving, because he did feel that the interest of the patient always took second place. And maybe that's acceptable with some innovations in care where you're not dealing with truly life-threatening diseases. But his mom had only a certain amount of time, and she couldn't wait for placebo-controlled, large population, longitudinal studies, which take 10 years. He knew she would be dead by then. And so he said, we're just going to find a better way.
So how did Dick come to recruit you to run CTCA, and what attracted you to the gig?
I was actually doing a turnaround at a McGraw-Hill company and brought in a talent expert to help me with that. And as we were working our way through this turnaround, he said, there's a guy in Chicago who's got a great idea in healthcare. He's an entrepreneur. He's got it started, but he doesn't know how to scale it. I'd love to introduce you to him because I think you could help him because you've scaled some major businesses.
So he was running one hospital at the time?
He had one hospital, was actually part of a hospital. He had bought a community hospital, and he was starting to introduce cancer into the middle of it. It wasn't totally dedicated to cancer at the time.
And what year was this?
Was 1998, 1999. I met him in 1996, and I came in 1999. So I said to this guy, I love great ideas. He told me about it. I said, that sounds intriguing, but I've never done anything healthcare. I'm not sure what I could do to be helpful. And he said, Dick doesn't need more oncology expertise. He needs somebody to help him run a business and grow a business. And so I was fascinated by his vision. I thought he was truly ahead of the market in terms of designing a hospital-based business direct to consumers, focusing on late-stage complex cancer with a very holistic and integrative care model. Many of these things were very much out of the mainstream.
And a lot of it is psychological, attitudinal, getting their patients in the right place, isn't it? You mentioned when we chatted earlier things like yoga and other ways to help people.
Yeah, yoga, Pilates, acupuncture, the psychology of healthcare, pet therapy, humor therapy, laughter therapy. And a key point in cancer treatment is that the disease and the treatment compromises your immune system. And at exactly the time when you need the most empowered and effective immune system possible. And so anything we can do to lighten the load on the immune system and make you feel better about it, make you feel motivated, manage nutrition, manage naturopathic intervention, helps with the basic cancer treatment. But when I came, that was not quite heresy, but it was very much poo-pooed by the traditional big box providers.
Was it called quackery? I mean, did they worry about that?
Yeah, it was called quackery. It was called selling false hope. It was called non-science-based medicine. And we've now done extensive validation work and have published 200 research studies published in peer-reviewed journals that prove up the efficacy of combining these different therapies with oncology in the traditional sense. And we still do all that stuff.
You didn't bypass the stuff that was known to have some therapeutic effect. You weren't doing almond extract in Mexico or any strange things like that.
Right, exactly. And now today you go to any premier cancer center and they all have an integrative medicine component and they have nutrition, not at quite the level we do it in our opinion, but this is all very much a part of conventional therapy now.
We all deal with this in different ways, especially with elderly parents. My dad passed away at a ripe old age after a battle with metastatic kidney cancer. And after some pretty awful experiences with the local hospital, we made the decision to just withdraw from the healthcare system altogether. I mean, it was so much better to have him live out his last year at home with dignity. Many cancers are still essentially incurable. Why is the standard of care for those patients so awful?
In American healthcare, there's a combination of some arrogance and a belief that there's always a small chance that we can do something. And you say incurable, the numbers are pretty compelling, but you can still find some people who beat the disease. I just was talking with a physician today who sent a patient to hospice 4 years ago with incurable kidney cancer. And 2 years ago, the guy called him, and through a whole nutritional program and probably some luck and maybe some, genomic
who knows,
luck,
right?
Yeah, he's now alive and he's doing well. So there's kind of that infinite hope and optimism that lurks. All of us as caregivers want to do everything we can to be helpful. There's also some perversion in the way the business works.
Particularly with Medicare patients. At one point, they turned my dad into a cash machine.
Yeah, well, they can be, and they certainly wouldn't admit that they look at it that way. They're doing everything they can. But then there are just some amazing stories that I think bring you back to our primary obligation to every patient is to inform, educate, and empower them. And we have some patients fully informed and empowered who say, I'm going to fight this to the end. I want everything, and I'm prepared to pay for it, and that's what I want. And many others will do what your father did, which will say, I'm not going to live forever.
It was
anyway.
90, right.
Yeah, and so I'm now going to decide how I want to manage quality of life and end of life. And that whole end of life conversation is another very complicated one that we're struggling our way through in this country in terms of what is our right as an individual to manage that part of our life.
So, Steve, the signature accomplishment of the Obama administration is supposedly the Affordable Care Act. Now that everyone has access to health insurance, why is self-pay the fastest growing segment of medicine?
Obamacare and the Affordable Care Act, there's good news and there's bad news in it. The good news in Obamacare is that we have, as a country, looked in the mirror, looked ourselves in the eye and said we're going to find a way to provide every American with access to quality care at a reasonable price. But then actually bringing that to life is very complicated. We can say everybody has access, but in reality, it's pretty hard for some people to access it. So we've got a lot of work to do in order to bring that to life. An unintended consequence of Obamacare is that it's dialed up into the front of everybody's mind the reality that healthcare is broken, we're going to fix it, and the act wants to give all of us the ability to access healthcare. So all of a sudden, I'm a player in the system as a consumer. It hasn't been that way. You know, my employer takes care of it or the government takes care of it. So now we're drawn into this, and the economic challenge then that's unfolded has really dramatically increased the high deductible health plan.
Sure.
And that puts the consumer right on the front end of the buying decision. They're going to dig into their own pocket before the insurance company's going to pay for it.
I mean, it could be even more.
Exactly. And so now I'm going to navigate healthcare differently. I used to get a referral, work in network, the insurance company will pay for it, don't think about it. And so now that self-pay component has grown dramatically, along with more rapid adoption of health savings accounts, which is almost the volunteer part of that, with the employer and the employee agreeing to create a high deductible health plan and fund it with money they can control.
Especially if you're in a high tax bracket. That's definitely the way we've gone, high deductible and just shoving money into the SSA.
Yeah, exactly. And the potential for that, I think, is enormous. It's too bad that we've shackled it the way we have with the caps on it. If you look at some of the other countries that have been doing universal access for a long time, there's some wonderfully effective models. Singapore being one, which has really created a combined super health savings account and 401k account. On a mandatory basis, every worker out of every paycheck puts 6% of their earnings into that. And that's available to them throughout their life to buy a home, to take care of retirement, to take care of healthcare expenses. And whatever they don't use can go on a tax advantage basis to their kids.
The impact of all of this is that it's starting to put the patient back in the main role as customer.
Yeah. I mean, that's fantastic. But the bad news of that is that as an industry, we're not very well equipped to provide the information that the customer is used to getting when they make complicated decisions everywhere else in their consuming life.
Well, this is especially important for terminal cancer patients whose prognosis, really under the standard of care, is largely a slow and painful death. And a lot of them, as you mentioned before, are blocked from experimental treatments by the FDA. If people have a right to die, at least in states that legalized euthanasia, why don't they have a right to try experimental medications?
And actually, that's a growing legal opportunity that they have. Several years ago, I was in a conversation with the folks at the Goldwater Institute, and we were talking about the long process of approving therapeutic innovations and the challenge of that for patients who have a terminal illness. And we were just saying, all this has to go through the FDA. Isn't there some way to give this back to the states? The Goldwater folks said, gee, I think there is. And so they crafted right to try legislation. It's now been passed in about half the states.
Wow.
And it basically says, if you're a patient and you're in a partnership with a doctor who says you have a disease that you're likely to die from within 6 months, you've tried the standard therapies, you'll sign a waiver and you want access to some unproven therapies that are promising, they don't look like they're going to be harmful, then you have a right to try that.
So when you say don't look like they're going to be harmful, you mean therapies that have passed phase 1 of the FDA trials?
Yeah, somewhere, exactly.
Okay, early.
Generally, yeah, right, exactly. But they're years away from final approval. We think that's just spectacular for everybody because you're informed, you can decide. If you want it, you can have access to it. And it also feeds the research, right? Here's another patient who tries it, you track it.
Let's see what happens.
And you can learn from that and accelerate the research theoretically.
I always thought from a public policy perspective, millionaires with incurable diseases ought to be the world's best guinea pigs.
Right.
Why don't we let them?
Yeah, exactly. Exactly.
Preparing to speak with you, I did a little background research, and I learned that there are a number of pharmaceutical companies that are actually reluctant to get involved in these experiments because they fear being punished by the FDA. Can anything be done to protect them from bureaucratic retribution?
Sure. I mean, under these state laws, the patient waives any right to action against the device manufacturer or the pharma company or whatever. And I think that generally, what the pharma company would do would be to ask for, or if the doctor could ask for, an off-label approval to use it in advance. And that's a fairly common approval for the FDA to offer. And we're seeing it more and more in cancer as we learn more and more about the genetics and the genomics of a cancer patient.
Off-label treatment is a whole field, and in fact, it's a minefield too, because the pharmaceutical reps have to be very careful not to push off-label treatments, otherwise they can end up in big trouble.
Right. So what's the scientific evidence that supports it? And with cancer, the state-of-the-art on assigning patients cancer therapy is back to these large population placebo-controlled double-blinded studies. So you and I both get a pancreatic cancer diagnosis. Our doctors go back to the gold standard and say we both should get this $80,000 12-week chemo treatment.
And 90% of us are going to die.
Well, not that, but we say, okay, so why? And they say because in the large population long-term study, this got the best tumor response for patients with primary pancreatic cancer. And we say, well, what does that mean? They said, well, 40% of these patients responded positively to this. And the next best population was 12%. And so we say, well, am I in the 40 or the 60?
Well, right, yeah.
And they say, well, that's why we're going to give it to you. And if you respond positively, you're in the 40. And if your hair falls out, you get mouth sores, and your tumors grow, then you're in the 60. And we'll look for something else. And now with genomic assessment, we're getting better and better at looking and saying, yeah, you're in the primary population, you should get it. But at a cellular level, my pancreatic cancer looks more like a melanoma. And so in this population, 5% of the people actually looked like me, but that's the therapy I should get. But I need an off-label approval to be able to use that. But the FDA, with that kind of evidence, with that genomic evidence, is more and more willing to say, go for it.
I mean, in a world that's changing that rapidly, isn't trial and error the best way to advance the science?
I think we hope for more than that. And with the genomic guidance, genetics are one thing, but genomics are basically how your genes are expressing different substances that can then be tracked to and compared to other things that are much more precise in diagnosing what you're dealing with. We can run big panels. We're still not perfect at doing the interpretation. It's better than trial and error,
sure,
I believe.
It's guided.
Yeah, exactly. It's scientifically guided. And it also continues to improve on itself. Every time we do one, we prove that it worked or it didn't work, and we can tie back and continue to track up. We also have, we have a huge bank of tumor tissue across the industry. When we surgically remove tumor tissue, we put it frozen in a tumor bank.
Oh, yeah, sure.
And so we have the ability now to go back and we can track what happened to that patient, how did we treat them, how did they do, what does the tumor tissue tell us about their genetic and genomic expression, and continue to advance the science.
Big data comes to our aid in that kind of world.
Yeah, and hopefully better than pure trial and error.
Right. Well, thinking about this on a global level and thinking about the reach of the FDA, does geographic regulatory arbitrage play a role in the self-pay movement? I mean, after all, a plane ticket is a fraction of the cost of serious medical treatment. What about setting up in the Caymans?
I think that's fair game, and it's happening. Healthcare City is opened in the Caymans, I think, last year, and created by a doctor from India, and it's primarily focused on cardiac care at the moment. But their offer is that their cost of delivering treatment allows you to get on a plane in Boston, fly to the Cayman Islands, get standard, significant, sophisticated cardiac care, recuperate in the Cayman Island environment and fly back for a fraction of the cost that it would take at, pick a hospital in Boston.
Well, presumably you'd also get access to experimental medications that the FDA may not allow.
That's true. Yep. You could. Now, this particular hospital is looking for JACO accreditation, so a U.S.-based accreditation. So it won't be the wild, wild west. It won't be a Mexican kind of an environment, but it opens up cost advantage. They promise standard of care that's even better, and there should be some access to experimentation that'll be different. And the Cayman Islands government has been very supportive, not only financially, but in terms of legal and regulatory oversight to try to bring this to life in the Cayman Islands.
So if you imagine a range of hospitals from one like the one you describe all the way down to the Mexican clinic, it almost sounds like we're recreating a healthcare market instead of a command and control system.
We are. We really are. And that wasn't intended by Obamacare, but I think it's going to happen with Obamacare. And you see it elsewhere around the world. In the UK, which has been a fully socialized, government-controlled medicine, again, the largest growing segment there is self-pay. And I think the point is that underneath all this are smart consumers who are living their lives. And if the government in the UK, which they do, says, you're 65 years old, we're not going to put you on the list for a hip replacement.
Right. Too bad for you.
And you're a 65-year-old who's healthy and can afford it, you say, I'll get my own. I've got a 25-year life expectancy.
I'll hop on a plane and take care of it.
Right. Exactly.
So, Steve, I'm only a few years away from Medicare myself, and so I'm not expecting a whole lot to change. But what should young millennials be looking forward to in the years ahead?
I think that the future of healthcare for millennials is filled with potential. Some of it's good news, bad news. They can't count on the system to take care of them.
Right.
If you run the economics, Medicare, Medicaid, not sustainable.
We baby boomers are going to bankrupt the system.
Yeah, exactly. Unless we start doing some smarter things, which I could talk about another whole half hour, and we need to do that. But the millennials, and I see a lot of millennials in my work at Harvard, people that are obviously navigating their lives. They're very interested in healthcare. And what they're doing is they're bringing their life's experience from everywhere else into the healthcare environment. And they're saying, if I can walk into a car dealer knowing more about the vehicle I'm going to buy than the car dealer, why can't I get that kind of information about my healthcare?
Fascinating.
Why can't I use my Fitbit to help me understand what I should be doing today? And there's more and more of that. But also, if I've got a symptom or if I've got a chronic disease, why shouldn't I have the information I need, be able to do what I need to do, have easy access to people that can be helpful to me?
This is a generation that's used to having every question answered on a device on their hip in about half a minute.
Right. And if they can't find it, they've got a whole social network that can help them find it. And it won't give them pure, immediately actionable information, but it'll feed their interest and they can follow it. And there are businesses growing up now that are designed to try to equip these people with transparent access to information that they can use to disrupt the old ways of the industry telling them what to do and just expecting them to pay for it.
Well, let's hope that ushers in a new age for our children and grandchildren. Steve, thanks for coming on the show and sharing your wisdom.
Oh, thanks for having me, Bill, and thanks for your conversation with your listeners. Anything I can do to be helpful, give me a shout.
That was Steve Bonner, former CEO of the Cancer Treatment Centers of America, here on Real Clear Radio Hour, brought to you by the Competitive Enterprise Institute. I'm your host, Bill Frezza. Real Clear Radio Hour is a not-for-profit, donor-supported program produced in conjunction with Real Clear Politics, America's premier independent political website. To make sure you don't miss any of our shows, stop by realclearradio.org and sign up for updates. Build your brand by aligning it with high-quality content on Real Clear Radio Hour. For corporate underwriting opportunities, contact producer at realclearradio.org. Ahead, we'll speak with physicist Paul Davies, whose move into cancer research is designed to shake up the big science establishment. Stay tuned.